I'm picking up where I left off in part one of the 4 osteopathic principles. In part one, I focused on the principle that states that the body systems are all unified, that we can't treat the body properly by thinking of them as separate systems. So this way of reducing things to individual parts and then understanding the parts is not complete. We then need to relate to the whole. And I also asserted that the whole doesn't stop with the physicality, but it includes the emotions, the mentality, spirituality as well. And so that then connects us with our environment, the systems of meaning that we interact with, the sort of content that we bring into our minds. Now in this one, I'm going to continue developing this idea of the oneness of our being, but also I'm going to begin to talk about how structure and function are interrelated. So I left off discussing the common compensatory fascial patterns that are described within osteopathic literature. And these were first described by an osteopath named Dr. Zink. So most of us, pretty much all of us, are not totally perfectly neutral in our bodies. In the transition zones, meaning where we go from head to cervical spine to thoracic spine to lumbar spine to sacrum, we have preferences. And most people have the same motion preferences. It's like 90% of people all do the same thing, 5% of people do the opposite, and then a small group, they're more random in how their body has achieved compensation or hasn't been able to achieve compensation. So in those two types, the commonly compensated people and the uncommonly compensated people, they tend to do better when they have injuries than the ones who are not compensated. So what compensation is that when one region goes one way, another region goes the other way. And then all of the regions together, they create a balance or a wholeness. The common compensation pattern is rotation left, side bending right, rotation right, side bending right, rotation left, side bending left, and then in the lumbosacral junction, it's rotating right. Uncompensated is just the opposite. So at the occipital cervical junction, it's rotating right, side bending left. At the cervicothoracic junction, it's rotating left, side bending left. At the thoracolumbar junction, it's rotating and side bending right. And then at the lumbosacral junction, it's side bending right, rotating left. In my clinical practice, I find this to be roughly true. You know, the common compensatory pattern is extremely common. The uncommon compensatory pattern is not so common. And people who are uncompensated tend to have more trouble when they have an injury. So this is normal. One way I see this show up is sometimes people will come in and they'll say, oh, I saw this other provider, you know, not an osteopath, and they said your hips are unlevel. And yeah, I could basically, anybody who comes in, before I even look at them or touch them, I could say, hey, your hips are unlevel. Because pretty much all of us have asymmetry in our hips. The most common case is if you're looking at someone head on, say this is their right hip and this is their left, is their pelvis does this. So it's not the fact that there's some asymmetry that means there's a problem. It's the degree of asymmetry and the restriction of that micro motion in the sacroiliac joint. So we actually have to see multiple findings to demonstrate that it's actually not functional. And that's because we're all compensated. So this may be functional here in the pelvis. A little bit of asymmetry is functional because it's balancing something up in the thoracolumbar region in the way the diaphragm is holding tension. And if we say, oh, asymmetry, that's bad, let's change that. Well, it's possible if we force a change there that will actually produce a problem that'll show up somewhere else or show up in that region. So this is one of the distinctions within osteopathy that hasn't really seeped out all the way yet. A lot of different osteopathic distinctions have seeped out, and a lot of people in bodywork actively try to learn from osteopaths to learn these. But this is one that's still mostly only appreciated within osteopathy, that asymmetry is not necessarily bad. We have to zoom out and look at the whole thing. So again, there's that principle in action. We need to consider the body as a whole. If we just focus in on an individual part, well, then we could end up chasing something that's actually not a problem at all. And this is one of the issues when people specialize on an individual area, a bodywork person. If like, okay, I only treat feet, or I only treat ankles, or I only treat, whatever region you want to say. Well, every region affects every other region. So if someone is a specialist in one region, well, they can't really be a specialist in that region unless they address all the other regions too, because you can have a problem in the neck that doesn't go away until you resolve something in the wrist. You can have a problem in the low back that doesn't go away until you resolve something in the ankle. And this is because the body as a whole. But let's start to also get into why we say structure and function are interrelated. And we can begin to understand this through considering a normal joint balance and a post-traumatic pathological joint balance. And the ankle is a really good one to use as an example. I use this one all the time because a lot of people are familiar with ankle sprains, either firsthand or someone they know or through a sports figure they follow. So in the normal status of any joint, there is a neutral. I mentioned this in part 1. This neutral, when we just go to rest, when we're not pursuing any activity, we're not activating any muscles, then the joint will idle in this neutral balanced position. And if there's no significant injuries in the whole body, well then all of the joints will come to neutral together if we're in a comfortable position. Laying down, it's pretty easy, or reclining, or even in some meditative postures, we can achieve a full body neutral. And as I mentioned in part 1, that neutral is deeply rejuvenating. Our perception of the body shifts to where it begins to feel very fluid and vibrant and expansive. And also, when we're in that neutral, the friction of time lifts. A lot of the times, most of us, we feel like we want whatever we're doing to be done so we can get to what we want to be doing. And time is kind of a drag. Or we need some sort of stimulus to keep our mind occupied so that we're not bored. But when we disengage and we settle into that deep neutral, the fullness of the sensation in the body and the sensory awareness is such that there's contentment. And in that contentment, the friction of time disappears. So that's the normal. And in that neutral, let's take an ankle, for instance. Let's say that there's someone's foot is facing towards the camera. Let's say it's the right foot that's facing forward. So like, big toe and then the other toes. And that here's the ankle. So if we were to take that ankle in a normal condition and then start to bend it this way into inversion, well, gradually as we did that, then the ligamentous tension would increase on that outer part. If we plotted it on a curve, it would just go up, 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 up. And the resistance would increase to the point where if we kept trying to bend it, we would damage something. So we could damage the ligament. If we went far enough, we could damage the bone. Right? Sometimes people sprain their ankle, and when they do that, the ligament actually pulls bone away. It stays attached to the bone, and it avulses the bone off of the bone that it's attached to. This will happen in the lateral part of the ankle pretty regularly with a very big ankle sprain. So at that point, when we begin to have damage, we are breaking an anatomic barrier. Before damage, but where motion becomes very difficult, we're at the physiologic barrier. So the sort of normal barrier for any sort of typical motion that wouldn't create an injury. So injuries, by definition, they violate at least the physiologic barrier. And then if you have some sort of tear or a fracture, well, then we've actually violated the anatomic barrier. So you can create this concept of a neutral in the middle, and then balanced around that neutral on each side, there are physiologic barriers, and then outside of that, there are anatomic barriers. So when a joint is uninjured, the neutral sits right in the middle. So you have about as much motion one direction as the other. This varies joint to joint because the function of the joint is a little different. An ankle joint is different than a knee joint. And so it tends to be easier for it to go into inversion than it is to go into eversion, just because of the strength of the ligaments. So sometimes that balance point is, even in a normal joint, it's shifted a little one way or the other. But it's still normal for that joint. And this also highlights, again, the function and structure relationship. So the structure is related to the function. So the ankle has to do something in particular, and so its structure matches what it has to do. Just like a chair needs to have 4 legs. A joint structure matches its function. Like the elbow, totally different structure than the shoulder. The shoulder is a ball and socket joint. The elbow is a hinge joint. And because those structures are different, well, they have different functions. Because they serve a certain function, they have a different structure. So which came first, the chicken or the egg? What I assert is that structure and function are one. There is no one coming before the other. They arise together. And we see this in all of life. This is actually a universal principle. This is not just an osteopathic principle. And look at the atoms themselves. Look at their electron valence shells, if you're familiar with that. The way those atoms interact with each other, well, it's based upon their atomic structure. And then that determines what functions they can have. So that's why we can use oxygen for our metabolism, right? That's why hemoglobin can carry oxygen through our bloodstream. That's why certain medicines will activate certain receptors. It's because of their structure. So this is another interesting thing, is that these osteopathic principles are also universal principles. There's no separate room called osteopathy. Our founder would talk about this all the time, really beautifully. He would talk about how the principles that underlie osteopathy are as old as the universe itself. So when you change that structure, you change that function. And an obvious change would be like a fracture. So we all know, if someone has a fracture in a certain bone, well, the joint closest to that fracture and adjacent joints, they're going to get more arthritis because their structure was changed. So the function of that joint was changed. And then the natural maintenance that occurs in that joint that's associated with normal structure and motion, function, doesn't happen. Those maintenance forces are repressed. So we get a buildup of arthritis. This is why any orthopedic surgeon you talk to will tell you, hey, if you have a bad knee injury, you're more likely to develop severe arthritis. You're more likely to need a knee replacement. Now, what osteopathy has done, starting back in the 1800s, is connect the dots to, okay, an injury leads to more arthritis. Well, what happened during the injury, and can we address that manually to help bring it back towards normal? And then in bringing it back towards normal, now we begin to touch upon this other principle, another one of these 4 osteopathic principles, which is the body. When I say body, I'm including the whole totality of a human being, not just the physicality, is a self-healing mechanism.